Hey everybody, thanks for joining us today. Myself, Dr. Ross Marchegiani, and here we have the amazing Dr. Chris Turnpaugh. How are we doing, Chris?
Great. Good morning to you.
Awesome. I'm really excited for today's talk. So we're going to be diving into small intestinal bacterial overgrowth, also known as SIBO. We'll be talking about how bile salts are extremely crucial for this process, or can be one of the issues that lack thereof that could lead into SIBO and increasing further endotoxins, and how this can shift what's called a Th2 dominance. We're going to dive into detail about this and talk about all the intercomplicated aspects and pathophysiology of this. So we're going to be talking about SIBO. We're going to be talking about how it shifts a Th2 dominance. And then we're going to be talking about short chain fatty acids, how it's really crucial for this condition. So let's dive in here. So Chris, do you want to lead off here and talk a little bit about SIBO and what exactly that term means?
Sure. And I'll probably even preface SIBO with some other things. But SIBO is small intestinal bacterial overgrowth. So when we think about like people taking probiotics and stuff, they typically live in the large intestine. They don't live in the small intestine. There's a few that do, but for the most part, most of our bacteria live in the large intestine. And when they translocate, which is to say migrate, which is to say move into the small intestine, they don't belong there. That's small intestinal bacterial overgrowth, or what we call SIBO. Now, SIBO, in my eyes, is really a condition of something else. So people specialize in SIBO and talk about SIBO. In my world, may be limited, but SIBO is the result of something. Now, maybe it's your bowels not moving, maybe it's constipation, maybe it's poor gallbladder function, bile salts, and maybe it's infection. So if we start off with a simple concept that our digestive system is what's called a hollow cavity inside of us, right? So it's really a moderation of an external environment. So if we think of our skin and we just fold in a tube that goes through us, it's really a pseudo exterior environment, much like our lungs, right? Our lungs are kind of an external environment. The female's, the vaginal cavity is an external environment. Sinuses are an external environment. It's modified. So in these environments, these hollow cavities or hollow spaces in our body, big stuff can get in there. And by big stuff, I mean pollens, tree pollen, dog pollen, parasites can live here. There's different levels of larger things that can get into our hollow cavities. And this brings us to an important immune identification. And it's much more complicated than this, but let's just suffice to say there's two halves to the immune system. There's in the help of the immune system. There's Th1 and Th2. And I don't want to turn everybody here into a clinician, but there's Th1 and Th2. Th1 stands for T helper 1. So it's when the immune system is asking for help, right? And Th2 is T helper 2. And so what kind of help is the immune system asking for, 1 or 2? Well, why would it call for 1 and why would it call for 2? When it asks for help from 1, it's asking for help from things that are small and can be eaten by a single cell. So like a little virus or a little bacteria that can be gobbled up by a single cell. Th2 is bigger things that cannot be eaten by a single cell, such as a pollen or a parasite or things like that. They tend to be in our big hollow spaces. Mold in your nose, all these big things that are in your gut, relatively big. So the gut is weighted more towards Th2. So it's typically a Th2 dominant structure. So if we think of it that way, we have to work hard to make sure that that balance, even though it's weighted to Th2, stays not overweighted to Th2.
Right.
Because if that Th2 dominance spills over to the rest of our body, that can lead to autoimmunity, that can lead to chronic inflammation, that can lead to all kinds of issues.
Right.
And so it's important to know that our gut is Th2, but we want to kind of keep the fire of Th2 contained in the gut.
Yeah. And I mean, that was said perfectly. That even from my standpoint, which I'm always still learning this and diving deeper, it's helpful just to hear that and hear that reiterated again. And it's a brief point that I want to make, in that I hear all the time from a lot of my patients, is a lot of like what they describe to me as histamine reaction, is hives or itching or digestive complaints. And from the practitioner side, I'm like, oh, well, they have a histamine reaction. But you have to take it the next step deeper and say, okay, well, where is this histamine drive coming from? Could it be another Th2 dominant pathogen or source that is causing this histamine to upregulate? And I think for some of these potential patients who are dealing with histamine reactions, hives, you go into a shower, you become very flushed, feel like you're going to faint, lightheaded, a lot of itching, maybe thinking about, well, let's stop just focusing on the histamine. Let's start backtracking here a little bit and figure out, is there another Th2 dominance factor that is triggering this histamine response? And for some of our viewers, we're going to be talking about SIBO and that being a potential further Th2 driver. So I thought that was great. And I think it's important to address some of the potential, what could be some of the potential causes of SIBO. How does SIBO occur? And obviously, we preach on diet, right? That's, I think, a pretty obvious one. If we have poor nutrition, or we're eating a lot of sugar, inflammatory foods, a lot of carbohydrates, and we'll talk about some specific diets in later on in this discussion. But obviously, that's one aspect. Stress is a major factor, but also other potential pathogens, whether it be like Dr. T mentioned, whether it's potentially could be H. pylori or yeast infection, or another type of bacteria or parasite driving and causing this dysbiotic environment. And that might be a new term to some of our listeners. Chris, can you dive in a little bit about about eubiosis and dysbiosis, and how dysbiosis trends to SIBO and IBS-like symptoms?
So dys meaning dysfunction, biosis meaning the microbiome. So the bugs that live in our digestive tract. Again, most people are familiar with the term probiotic, or apple cider that goes hard and fizzy, or sauerkraut that turns sour. Those are bugs doing that. So when you take these bugs in, they live in our digestive tract, again, largely in the colon. And think of that as a neighborhood, and the neighborhood where everybody gets along and everybody shares and everybody's happy. And then when you have dysbiosis, you either have too much of one type of bug, or commonly the wrong type of bug. So, then the neighborhood went south because criminals moved in, or whatever analogy you want to say. So it's not exactly the right neighborhood for what your body's asking for. And this leads to inflammation. This leads to changes in the feedback between the digestive system and the brain. So you can have emotional disorders based on dysbiosis. And then if you have these bugs give off gas, right? So that's how we produce our own hydrogen and methane, or when we pass gas or flatulence. These bugs eat stuff and they give off gas. That's what they do. Well, if there's the wrong type of bug giving off too much gas, what happens is, think of the large intestine. On the bottom, we have our anus and rectum, really the rectum that holds it in. And the other side, going backwards, upstream, is a valve called an ileocecal valve. And it's just basically the door that shuts between the small intestine and the large intestine. But if we have too much gas being given off in the large intestine, it puts back pressure on this ileocecal valve, or the door between the small intestine, large intestine, which allows that door to open up. When that opens up, the bugs will migrate from the large intestine to the small intestine, and that's where we say they translocate. So they have now moved from the small intestine, or from the large intestine to the small intestine. And now it's really important because the bugs that migrate may be the friendly ones and may be the pathogenic ones, but they're still living in the wrong home, right?
Bingo.
So it may be the right bug in the wrong location. So it may be the right bugs living in the small intestine. Well, they don't belong living in the small intestine.
Right. And I think we get, some people in the community get so inversed in, okay, well, we know it's a shift in probiotics, and we need, we need to re-inoculate and reculture the digestive tract or the small intestine, and we go right back into probiotics, and we might be adding some fuel to the flame. So
100%. So if you're adding bugs to an overbugged population, it doesn't matter if they're good or bad. It's still the wrong thing. And these bugs that are living in the small intestine, they're not bad bugs. They may not be.
Right.
They may be the right bug. And so when you add probiotics to someone with too many bugs, you do two things. You're repopulating in an area of the intestines where they don't belong because you're putting it in the small intestine. And by doing so, you're creating that Th2 dominance, or that inflammatory dominance. Now you have inflammation in the gut that you're adding to by adding probiotics. And that inflammation leads to things like lack of motility, which means you're constipated, which means the bugs can't even get out of the small intestine, which means you're going to promote SIBO. So it becomes a vicious cycle. You have GI dysfunction, and the practitioner doesn't recognize that it's a SIBO type, or a small intestinal bacterial overgrowth. So, digestive issues, you need probiotics.
Right.
Except when you take the probiotics, it makes the situation worse.
Right, exactly. And so I think that was perfect. And then there is a lot of deciphering and confusion between SIBO and IBS, which is irritable bowel syndrome, which is just basically a label that is slapped on a patient due to multiple symptoms presented by that patient, whether it's gas, constipation, bloating, acid reflux, nausea, abdominal pain. That pretty much encompasses a IBS type patient. So Doc, what do we do here from the patient perspective when they're sitting there, they're in pain, they have gas, they've got bloating, they don't know what to do. They're going, do I have IBS? Do I have SIBO? What direction do I go here?
Well, so this is where it's important to dive in deep, like you always say, to dive in deep, because do you have lack of GI motility, which led to the bugs migrating? So if you're not moving things through in the one-way street of the digestive tract, then it allows it to be a two-way street. That's a problem. So do you have proper GI motility? The other piece, which you kind of alluded to at the beginning, is do we have proper bile salts being excreted by the liver and then the gallbladder? Does the patient even have a gallbladder? The bladder means a holding tank, right? We have two of them in our body, gallbladder, urinary bladder. If we didn't have a urinary bladder, we'd drip urine all day long. Gallbladder is very similar. So we store our bile salts in the bladder, in the gallbladder. And when it gets squeezed out, think of it as like a binder. It binds stuff up and moves things through. It also emulsifies our fats, but it binds stuff up and moves things through as a binder. So this can lead to, as we discussed earlier in a previous one, hormone dysregulation, and also any biotoxin or toxin in our digestive system that we've eaten or we've come in contact with, molds and things like that. Very important that the bile comes out of the gallbladder, binds up whatever it's supposed to in like a straitjacket, is used the analogy. It binds it up, takes it all the way out, and has to continue to flow. The other piece is it can be linked to like early Parkinson's. So Parkinson's, the first sign of Parkinson's is constipation because you don't have proper movements, right? So the other piece, as you alluded to, is stress. When we get stressed, we shut off rest and repair, digestion, we shut that off and we go to fight or flight. So fight or flight, feed, breed, rest, repair. So if we're under too much stress, we don't have proper digestion, we shut down that digestive piece, and then that leads to inflammation in the digestive tract. And I think we're going to talk about in a bit how that leads to loss of tight junctions and leads to leaky gut and leads to inflammation. So we'll get into that. So it's important that when you come in to differentiate, so if somebody says they have irritable bowel, that by definition means it's in the bowels, but nobody delineates that.
Right.
Is it in the bowels? Is it in the small intestine? Where is it? So we want to say, hey, we recognize your symptom. We need to tease out what is the mechanism of dysfunction. Is it liver, digestive? Is it gallbladder? Do you have a gallbladder? Are you able to emulsify your fats? Do you have an excess of biotoxins? Are you exposed to mold? Do you have excess stress? Do you sleep poorly? Right. So it's not, we pride ourselves on this as far as, pride is the wrong word, but we value the fact that two cases are not the same. So if somebody comes in with these inflammatory bloated feelings, it could be a matter of one of 6 or 7 different things.
Right. I think that was perfectly said. I love that. So just to kind of recap, because it was so much good content coming at you here. So we could, in regards to SIBO, we need to figure out, or I shouldn't say, it would benefit the patient significantly to figure out what is the source of this small intestinal bacterial overgrowth. It's important that we look at bile salt production, right? And thus looking at liver function, because we know the gallbladder is where our bile salts are stored and our bile acids are stored, but we know the liver is responsible for the production of these bile salts. We want to make sure that we are looking at our door, right? The ileocecal valve, and making sure that before we start re-inoculating, that we close that door and we start pushing out this translocation of bacteria. We also want to make sure we look at the stress. We want to make sure we get to the root cause issue, not just cover up the symptoms here.
Important. Go ahead.
Yep.
Well, I was just going to piggyback on that and the reason that is so important is if SIBO was just bacterial overgrowth in the small intestine,
right,
that we could wipe it out and hit reset.
Right.
There's a drug that's used quite often, rifaximin or Xifaxan,
Bingo.
And it's a non-absorbable antibiotic, so it kills the bugs in your digestive tract, but doesn't really have an effect systemically.
Right.
If we were able to just say that's if your problem was only SIBO, we would solve it by going on this antibiotic that killed the bugs in your small intestine, and the world would be a better place. But we know that doesn't work.
Exactly. And Doc, I love we're on the same page, because there's an awesome, I was saving this to a little bit to the end, but we'll talk about it now, perfect time. There's a great study that's done by Johns Hopkins, a somewhat reputable, profession here or hospital. Yeah. So very reputable hospital here that's doing research on the use of rifaximin versus, which I'll talk about in a little bit, a couple natural herbal supplements in the treatment of SIBO. And the big thing that they saw with rifaximin and neomycin, because usually they'll use those interchangeably, is that it got rid of symptoms, but reoccurrence rate was up towards the 90s and 95 percentile, meaning patients felt good when they were on their rifaximin. Afterwards, after the 14-day, it's typically about a 14-day treatment. And then afterwards, they noticed SIBO symptoms came back, meaning they did not get to the root cause issue, did not take care of what started the SIBO in first place. So we'll dive in a little bit deeper into what some of these other herbs that they used. But I thought it was really interesting that they found that the use of rifaximin had a very high reoccurrence rate of symptoms. and that they found that some of these herbs we're going to talk about a little bit later on were more effective in the removal of SIBO when compared to rifaximin, which was amazing.
We there's things in history that we tend to forget. And for thousands of years, they've used herbal bitters. And that may be some of the herbs you're referring to at Johns Hopkins. But these herbal bitters hit the first part of the small intestine and they trigger motility, which is to say movement.
Mm-hmm.
How are you going to get the bugs out if your guts aren't moving? So if you just use your herbal bitters, that's probably somewhat has to be considered as an important step to get the GI motility moving along. So it's not like we should forget about 2,000 years of empirical evidence and just go with, this is, I understand this completely.
Right. Or the new shiny toy. Let's use the new shiny toy. Wait, this has been working for a long time. So let's go, let's dive back into the bile acids and then the immune response, because I think some of our listeners want to dive a little bit deeper into what's going on here. So we talked about the bile acids and in the aspect of really important binding these endotoxins. But when we don't have the bile acids, we don't have enough bile acid formation, then we start having free circulating and increase the circulation of these endotoxins. And it's when these endotoxins start to translocate and they start to damage the epithelium of the tight junctions. So basically it starts to damage the wall of our intestines, right? Through paracellular, typically paracellular permeability. Now I know we have the paracellular and transcellular, but we're getting in some semantics here. But basically it damages the cell wall. Now we have this endotoxin starting to get into our bloodstream, and then we are further pushing these pro-inflammatory cytokines and pushing Th2 dominance. Do you want to talk a little bit about that, Chris?
Sure. So we have this balancing act of Th1, Th2, and it's balanced in the middle. The fulcrum is something called a T regulatory cell, and that's mama bear. Mama bear regulates the ones and the twos. So we want to make sure that we have a healthy, robust regulatory response. So it's okay to have inflammation as long as it resolves. It's the lack of resolution of anything in our body that leads to chronic disease. So we could say chronic disease is analogous to lack of resolution. So if things resolve, they're not going to come in our office. If they persist, they're going to come in our office. So we have this Th2 dominant hollow cavity called our digestive system. So we're weighted a little bit more towards Th2, and that's always the case. But it's contained through our border patrol. Border patrol could be our skin, but if we fold our skin in, it's our digestive system. So we have this border patrol called our digestive system. And we've talked about this in previous podcasts about the brush borders and the whole 9 yards. So we have these cells, and what happens is the paracellular means around the cell. Transcellular is through the cell, paracellular, as you alluded to. So these tight junctions get opened up, and these big things, these lipopolysaccharide endotoxins, can go into our immune system. Now, they've crossed the border patrol, and they've gone into our system. So we've already said these things are big. They're too big to be eaten by a single cell. Things that are too big to be eaten by a single cell are Th2 dominant. So now that burden of Th2 isn't just in our hollow cavity, the gut, it actually goes into our entire system and drives a Th2 response in our entire body. What does that mean? Well, Th2 will drive something called Th17, and Th17 is the marker for chronic Th17 is a marker for inflammation and autoimmunity. So what this means is if we have an inflammatory response in our gut and we lose those tight junctions and big things, whether it be a food peptide or an endotoxin, leak through our gut, that's going to trigger a Th2 response systemically. The systemic Th2 response drives systemic inflammation and increases the probability of chronic disease, specifically autoimmune disease.
Yeah. So perfect. Exactly. And I think that's crucial for our viewers to understand, that SIBO, if left long enough, we can start having other autoimmune issues arise. Hence, I love that you put the aspect of Parkinson's, right? I mean, this is an autoimmune condition. Granted, some of it can be genetic in nature, but there are aspects that we need to realize that can start popping up other conditions. So it's helpful to be aware that if not managed, this can turn into a slippery slope pretty relatively quickly here. So, Chris, I wanted to talk about how we differentiate between SIBO and whether we're dealing with some other IBD or IBS condition. So, potential SIBO patient comes in, we probably should be telling them that, or recommending a lactulose breath test. Can you go into that a little bit, Chris?
So this is a tool that's used. It's the standard. I don't use it very often, but it's a tool that's used. I say you drink the goo and you blow into a kazoo, right? So you drink this stuff and then you blow into this thing, it looks like a kazoo, and it gathers in a bag. And these bugs, when they eat stuff, they give off a gas, as we alluded to earlier, and it can be hydrogen or methane. And if you have abnormal amounts of hydrogen or methane, that's indicative of certain types of bacterial overgrowth. So that's really the hallmark way, the gold standard to do that. And humbly, I don't do that very much. I know you do it more, and Dr. West here does it all the time. I would say, and then there's the other test, which is what I call the bedside test, which is what I do more, which is, do you bloat when you eat? Yes. Do you bloat when you eat anything? Yes. So you bloat when you eat protein, when you eat fats, when you eat carbohydrates? Yes. If you bloat when you eat anything, that's a hallmark sign of SIBO. If you only bloat when you eat protein, that could be stomach acids. If you only bloat when you eat carbohydrates, that can be candida, that can be different things. It could be pancreatic insufficiency. If you only bloat or feel bad when you eat fats, that can be gallbladder. But if you bloat when you eat everything, it's probably some form of SIBO. Yeah. So that's how it could be done, what we call bedside testing. Yep. If you want the actual documentation, it's the breath test, the hydrogen methane breath test.
Yeah. Perfect. Awesome. I love that. And it's great to hear that, Chris, because it brings you back to ground level. Like, okay, let's just use some anecdotal evidence that's being reported by the patient. Let's just listen to our patient here and get to this quicker here. So I love that. Thank you for bringing that back, because that helps me as a clinician and actually, not being so dependent on numbers, which we can really get fixated on that.
Right.
So Chris, patient comes in and they present with SIBO. They have, we for this case, the scenario, we run the lactulose our lactulose breath test. We blow. I always tell my patients that you drink the goo, you blow in the kazoo. I love that. It's great. So they come in, they're positive. They have high, let's just say in this case, we'll make it easy. They have high hydrogen. They don't have high methane. It's just high hydrogen, which we know is a little bit easier of a case versus, methane, or unfortunately for some patients, having both high hydrogen and high methane. But we know if they're higher in hydrogen, it's typically more diarrhea presentation, versus if it's methane dominance, we can see a little bit of a mix of both, but it tends to be methane is a little bit more constipation. That's just some arbitrary information. But coming back, patient comes in, they have high hydrogen. What are some approaches that we're taking for our listeners that they can do at home or implement in regards to some of the treatment with that?
Well, there's a couple treatments. Remember that if you have small intestinal bacterial overgrowth or any bacteria, they require food to survive. So they're eating food, and then they're passing gas, right? That's the hydrogen or methane.
Right.
So if the food, and typically these guys live, or these bacteria, I don't want to give them a gender, these things live in the colon. By the time the food gets to the colon, it's usually extensively broken down into its fundamental constituents. So if the food isn't broken down, the bacteria can eat more of it, right? So one of the things to do is to make sure your food is properly broken down. One of the ways to do that is through digestive enzymes. So digestive enzymes help to break the food down, ensuring you have enough stomach acid, right? So the stomach acid, we talked on a previous podcast, the stomach acid is what triggers the cholecystokinin release to tell the pancreas to make enzymes. So you need to have enough stomach acid. Make sure you chew your food. Chewing your food is incredibly important. And there's also some benefit for fasting, periods of fasting, to not eat. You want to ensure the liver's working and the gallbladder's functioning, and you have a gallbladder. So there's a lot of steps, as you alluded to, that we need to assess before we even get into it. We could take some approaches like, let's go kill those bugs too. I mean, that we can go in with killers, whether it's Xifaxan with an antibiotic, because that has some benefit. We just need to follow up with the efficacy of restoring normalcy.
Absolutely. I love it. And then also, which I even tend to forget, being a chiropractor, get adjusted, right? Like, how about that migratory motor complex, right? The aspect of the nerves firing signals to the small intestine to get our peristaltic contraction, right? So basically, peristalsis is just our small intestine is a muscle, right? So it's just the contraction of that muscle and moving the food along that pipe. And if we're not in proper alignment and we're not holding our adjustment well, let's take care of the inflammation, because probably inflammation is causing you to not hold your adjustment. And let's make sure you are getting adjusted, so we're getting correct nervous signal to the small intestine and having a good migratory motor complex.
I think that's brilliant.
Yeah. And then a couple other things, because I told them I would give some information in regard to that Johns Hopkins study. So basically, some of the herbs that they used like some oil of oregano, they used wormwood, they used red thyme, they used some barberry root. Let's see what else. Those were the big ones that they used. So those are some things that you can implement that all show efficacy in killing some of this translocated bacteria. And then once that's done, then we can talk about using some good probiotics. Using, Lactobacillus plantarum is a really good probiotic that showed benefit with SIBO. Also, Lactobacillus casei, Bifido brevis. These are some good probiotics that are helpful in re-inoculating. But I don't want to dive into all of that because, again, as we alluded, Chris, right, getting to the root cause issue, what's driving that SIBO? What's the root cause?
Well, I think that's important. So if you look at some of the things they use, like red thyme and barberry or berberine with the oregano, these are pretty potent killers to reset and kill off some of those bacteria. But they also probably have modulatory effects towards GI motility. So the things with these oils is they're not just one thing. And then that also helps to shift towards a Th1 response. So if our seesaw is too far out of balance, berberine, for example, is an IL-12 facilitator. So it helps to balance out that Th1 response. So these are herbs which have harmoniously grown up with us over thousands of years, probably have a different effect than a man-made chemical, non-absorbable antibiotic like rifaximin or Xifaxan. So I think there's probably benefits to these antimicrobials that are natural and broad spectrum. The other piece is the like oil of oregano. If you take an antibiotic, you may be promoting candida. If you take an antibiotic, you may be promoting even a virus. And But if you take oil of oregano, it's broad spectrum enough that it has antiviral, antifungal, and antibacterial effects. So you're kind of being more complete. At the same time, it's something that has grown up synergistically with the human body over thousands and thousands and thousands and thousands of years. And it's important to notice, we learned a long time ago, we don't want to shut a pathway off. And drugs, many times, in times of crisis, we need this, but in times of ongoing chronic inflammation, maybe not as much. Yeah. A drug can shut down the entire pathway, but a nutritional supplementation is going to modulate the pathway instead of kill a pathway. So
I love it. I mean, can I just say, mic drop? That was great. And then also, guys, ladies and gentlemen, our viewers, let's talk about food real quick here, right? Like, I know everyone, when it comes to SIBO, first thing that pops up, low FODMAP diet, right? What's that stand for? It means you're avoiding foods that are your monosaccharides, oligosaccharides, excuse me. So FODMAP is, oh man, why am I blanking on the F here? It's
fermentable.
Yeah, thank you. Duh, right? So our fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. That's basically the acronym for FODMAP. Basically, it's long carbohydrate chains, long protein chains, but more in the carbohydrate realm, longer chains that will create, that are one, harder to break down, and two, when you break them down, they create more methane and hydrogen. They can create more gas. So but the big one is FODMAP diet. You could also look into the SCD, that's the specific carbohydrate diet. You can also look into the GAPS diet. That's the gut and psychological syndrome diet. And then there's another one that has to do with like fermentation potential. I'm blanking on the gentleman's name who made it, but he like talks about you categorize your food, you use his app, you punch the food into the app, and it gives you a fermentation potential, and you're supposed to keep it under a fermentation potential. I like going back to Chris, your philosophy. Let's keep things simple here, right? KISS, keep it simple, stupid, right? So those are some diets that you could look into. Do you want to comment on any of that, Chris?
Well, I think that you're spot on. My concern is if you're on a FODMAP diet for 5 years, we're missing the underlying mechanism. Yeah. So, and I'm not saying it's always easy to find, but if you have to stay in a FODMAP prison for life, if you eat any food that's fermentable and it ferments, or fermenting, remember, is bubbling, right? So then that's probably, we missed the underlying mechanism. And so this is something that should be brought to a resolution. Now, I'm not going to tell you that everybody finds that pathway, but that's our goal, is to find out how can you live a normal life and not eat strictly a FODMAP diet or be in food prison. And that may be, again, the aspects of how's your brain working to make dopamine to drive GI motility. That may be how's my digestive system working to make bile salts to bind up these things. And that may be, do I have enough stomach acid to trigger my pancreas to make enough digestive enzymes? That may be pancreatic insufficiency, so maybe I need to take some digestive enzymes. That may be, maybe I have leaky gut, which has led to these endotoxins going into my body, leading to a Th2 dominant response or an inflammatory response. That inflammatory response then triggers the gut dysfunction. That may be I don't sleep well at night, so my cortisol rhythm is off, so now my circadian rhythm's off, so I don't digest well. So I think the key point, without belaboring it, is this is something that should resolve over time.
Yeah, I think that's perfect, again, because it even brings me back to like, well, maybe we'll have to deal with it. No, we should be getting to the root cause issue here. This shouldn't be an ongoing issue. So I think that's perfect. I think we covered pretty much everything here. I know probably one question that some of our viewers, I know my patients have had when they talk about SIBO is, can I do fermented foods? So it depends where we're at in the treatment, right? Like we talked about, if we do probiotics early on, we are just adding fuel to the fire. And when we talk about fermented foods, I want you to think of that as like your probiotic supplement, right? But if we add it too early on, it's going to put more gasoline on the flames here.
Correct.
Anything
And,
else?
I want to encourage people too that, as you alluded to, with things like oregano or different products like biocidin and different things that we use for SIBO, you may have to reduce the pathogenic burden. So if you have all these bugs living in the wrong place, you may have to kill them. So I don't want to rip on the Xifaxan too much. It's helpful as a first step, but we need to go through the entire protocol or treatment plan to restore function. So yeah, you're exactly right. And so putting in the fermented foods early on is like taking a probiotic. So we're adding bugs to an already bugged situation.
Right. So you can, for the viewers, you can do fermented foods, sauerkraut, kimchi, kefir, a little bit questionable, but you can do that. Natto, these are all good fermentable foods, but it's like everything in life, it's all about timing, right? So I think that's it. Do you want to talk about short chain fatty acids at all, Chris, or do you feel?
Well, sure. So I'll quickly go into this because it's important, maybe not as much for SIBO, but just for resolution of gut issues. So when you eat vegetable fibers or vegetable products, when they're broken down into their final product, right, that's called a short chain fatty acid. When you get into the large intestine, the gut, and to some degree the small intestine, but usually it's the large intestine, when these short chain fatty acids hit a colonocyte, which is a colon cell, the cells in the colon, it triggers a regulatory cell to be predominant. What does that mean? The regulatory cell is the fulcrum. Remember I said it's mama bear, it regulates the TH1 and the TH2. So if you have a slight imbalance, who regulates that a lot is the Treg cell, the regulatory cell. The short chain fatty acid, which is the end product of vegetable fibers, drives that Treg cell in the colon. So short chain fatty acids are incredibly important to resolve ongoing inflammatory responses in the colon. Now, they've done these in the hospital, actually, in enema bags. But if you take them orally, it's propionate, butyrate, and acetate. Yep. So most common one is butyrate. If you take it orally, it helps to calm down the overexcited immune state of the large intestine. So many times we'll use these short chain fatty acids to resolve or regulate the dysfunction of the gut. So think of these short chain fatty acids, which most of us get by digesting vegetable fibers, right? So, and it's important to recognize here, like if you're on a keto diet or a carnivore diet and you're not even getting vegetable fiber, or if you're a vegetarian and you're not digesting your vegetable fibers, you never get to those short chain fatty acids and you never get to digestive regulation.
Yeah, perfect. I think that's the cherry on the top there. Yeah. That was perfect. And again, this is a complex situation that needs to be, that I feel that if you're someone that's been struggling with this, reach out to a doctor like Dr. Chris, reach out to myself, reach out to another practitioner at another great clinician at Turnpaugh Health and Wellness Center, and get to the root cause issue instead of just covering up the symptoms. Is there anything else that you want to add there, Chris?
I think that's a complicated subject that you've broken down pretty simply.
Yeah. I think this was a great talk, very informative. For our viewers, if you need to, if you want to reach out, please again go to the Turnpaugh Health and Wellness website, www.turnpaughhwc.com. And if you need to reach out to the office and you want to schedule an appointment, the number is 717-795-9566. And please don't hesitate to like or go to our YouTube page or like our podcast here and share information with others.
Thanks so much for having me today.
Awesome talk, Chris. Thanks, everyone. Have a good one.